Yeah, so this is Jan Fritz from NYU in New York City, and it's my distinct pleasure to introduce Dr. Michael Alaia from NYU. He's one of our sports surgeons here at NYU. He's an expert in arthroscopy with a focus on knee reconstructions, where he is a nationally and internationally recognized speaker. He's also a prolific researcher. He has published over 75 publications and is the PI on multiple randomized and multi-center trials, all focusing on knee ligaments. He's the expert for knee surgeries, but also for ACL revisions. And probably his most important attribute is that he's married to one of our MSK radiologists, Erin. So Michael, please go ahead.
Thank you, Jan and Hillary, for having me on this. I love how my most important attribute is being married to Erin. I hope that she says the same about me, although I doubt it very much. It's a great privilege to be talking to all of you today. As we're going to see, we're going to talk most about one of the things that I hold true to my practice is revision ACL reconstruction. It's a very complex issue, a very complex surgery, and as a surgeon that does a lot of these, you have to really focus on a lot of potential issues that may arise. And this talk is going to be more clinically based than radiology based. I'm sure that most of you can diagnose these things better than I can on an MRI scan, as well as the associated pathology that comes with it. Although this is designed to enlighten everybody in terms of what we look for as surgeons, and maybe go over some cases and interesting cases at the end of this talk. So these are my disclosures. So the impact of ACL failure is quite large. You know, we know that ACL tears are extremely common in the United States and around the world. In the US, we've got about 200,000 ACL injuries per year, and the great majority of those get reconstructed. Now, anytime you do a reconstruction, you're going to have some component of failure, right? So if that failure rate is 5 to 10%, then obviously we're going to have a tremendous amount of failures in this country as well. And we would like to prevent that, given that they have a significant financial as well as emotional burden on players and athletes in our society. Now, people might be getting older, but they're also getting younger at the same time, right? So 50 is not what it used to be. 50 is like the new 30, and that's pretty much what we talk about. There are lots of patients that are getting older in age, although physiologically they might be younger than me. And back then we could have told them, wait on your ACL, don't have it done. But now these are people that want to be aggressive about getting back on the ski slopes, the tennis court, etc. We can't simply turn those patients away. We have to treat them as if we were treating ourselves. So when we talk about failure, it's critical to understand what failure is. Now, failure can be a rupture of the graft, or it could be functional instability despite an intact graft. You could also have issues with arthropibrosis, stiffness, infection. So failure is really a term that we use for a lot of things. It doesn't just mean the graft is ripped. Clinically, there are many things that we talk about when a patient is not doing particularly well after an ACL surgery. And like I said, these are all ways that we can define failure, whether it be graft-free rupture, persistent symptoms, return to play. Patients with a stable knee might just not psychologically have the ability to return to play after one of these injuries. So the definition of failure is really critical in how we go about treating these patients. And in terms of why they fail, I like to break it down into things that we can control and things that we can't control. So stuff that we can control as surgeons include the surgical technique, how we're drilling our tunnels, what kind of graft we're picking, the ability to recognize concomitant pathology, whether it be a meniscus tear or a collateral ligament injury, as well as alignment. I order x-rays, full length alignment films on every patient that comes in with a ruptured ACL graft, because significant varus or valgus can put significant forces on that graft that we don't want to see. And then sagittal alignment, I'm going to show you as well, is critically important. Then there's things that we can't control, like patient factors. Are they compliant with their physical therapy? Are they smoking? Are they doing stupid things out there just 2 weeks out from surgery? Graft factors, was the graft irradiated? And then, like I said, things like infections and arthropibrosis, which we can't really control that well. In terms of the MARS group, this is the multi-center ACL revision study. We know that the great majority of our failures are either technical or traumatic. When it comes into the issue of multiple graft failures, they tend to be more technically based in terms of meniscal deficiency, where your tunnels are, et cetera, et cetera. So again, these are things that we have to think about as surgeons, and the rate of technical error goes up as the number of revisions goes up with it. Now, in terms of technical causes of ACL reconstruction failure, the great majority of the technical issues have to do with tunnel malposition. Where is the tunnel placed in the femur, and where is the tunnel placed in the tibia? It can be one, it could be the other, or it could certainly be a combination of both. And these tunnels come into critical importance when we're talking about revision surgery, because either we have to use the old tunnel, go around and create a new one, or potentially integrate some of that old tunnel in with a new tunnel. And revisions certainly are not benign. It's not a second primary ACL reconstruction. Like, oh yeah, it's just like the first one. Let's go in and do an ACL on it. That's really not what happens. The graft re-rupture rate is a little bit higher. There's higher failure rates. There's greater cartilage pathology. So these patients may have pain or effusions or swelling. Meniscal deficiency is very common. Stage procedures are common. There's inferior outcome scores, lower return to sport, as well as bone loss, which I'm going to talk about. So for me as a surgeon, you've got to be prepared. The game plan is just as important as the technical performance. You know, you talk about Yogi Berra's famous comment, being, you know, baseball is 90% mental and the other half is physical. You could say the same thing about ACL revision surgery. If you're not really coming in prepared, then you're going to be doomed to fail. So lesson one that I've learned with many years of success and failure is patient selection. Know who you're going to operate on, know what they need, and know what your potential pitfalls are going to be in treating these patients. Now, the other thing we have to think about is how much surgery is too much surgery rather. Patient comorbidities come into play, their type of employment, their support status, whether or not they're going to have access to physical therapy and access to your care. Most revision ACLs that we do, we tell them, yeah, you need 2 to 4 weeks on crutches and then you'll probably be fine. But in the cases of an osteotomy or a cartilage restoration procedure or a meniscus transplant, it certainly could be longer. It could be more surgery. It could be a greater risk of arthrofibrosis or failure. And some patients are simply not going to tolerate too much surgery. So like I say, the above may change the conversation completely. And it's not a cookbook. Not every ACL revision is the same. So we have to take that cookbook philosophy and kind of throw it out the window, because there is certainly an art to treating these patients. You have to have a clinical gestalt as well as a radiographical gestalt in terms of what's going on with these patients. In terms of what I do preoperatively to evaluate these patients, the history and the physical obviously are of the utmost importance. This is a gentleman who had an ACL tear, and I really want you to watch the way he walks. You know, we're going to play it again and watch his right knee. Look how it kicks out into varus every single time he throws his knee out there. So if I did an isolated ACL reconstruction on this particular gentleman, I would fail, because every step he takes, his knee is going to go into a dynamic varus and he's going to fail, right? So the physical is extremely important, as well as the history. You know, when did it tear? How did it tear? What are the patient's goals and expectations? The initial operative report obviously is extremely critical. It tells me the type of implant that was used, the graft type, whether it be autograft versus allograft, tells me the tunnel placement method and the diameter. What was the tunnel when they drilled it? Was it 8 millimeters, 9 millimeters, or was it 12 millimeters? You know, has there been significant tunnel osteolysis? Has there been any significant meniscal or chondral work done? And then the arthroscopy pictures, if I can get them, then that's obviously very helpful for me. So in terms of the radiographic workup, I'm pretty aggressive. So I always get 4 view radiographs. I'll get an AP standing, a PA flexion standing, lateral image, as well as a sunrise image. Leg length alignment films are of the utmost importance to tell me coronal alignment as well as sagittal alignment. What is the tibial slope? Tibial slope is extremely important for ACL tears, and I'll get into that in the near future. Sometimes stress radiographs are needed, where I have to apply either a varus or a valgus stress on the knee to see if there's any significant medial or lateral joint space opening. The MRI, as you know, is the gold standard, as well as CT scans. And the importance of CT scans is to talk more about the idea of bone loss when it comes to ACL revision. So I know for radiologists, they know a lot about bone loss in terms of shoulder instability, right? You know, 3D reconstructions, look for glenoid bone loss, look for Hill-Sachs lesions. But the same can be said from ACL reconstructions as well, because as tunnels increase in size and their position may vary in the knee, it's important for the surgeon to understand what the tunnel looks like and where it's positioned before just diving in and saying, oh, hey, you need an ACL revision. Let's get going. So Tunnel position and hardware placement is extremely important for me to assess when I'm looking at a revision ACL. So these are the routine images that we take. X-rays, obviously, your gold or your standard, but the problem is patients have different rotation on X-rays. It's limited by the quality, limited by rotation, limited by inter and inter-observer reliability, but it's very basic when you're talking about bone loss. And you can see it. Look at this picture on the top left here. You can easily see where the tibial tunnel is. You can easily see where the femoral tunnel is. It's probably a little high, a little anterior. You look on your lateral film as well. You really want to see that tunnel starting behind Blumensatz's line, right? If your tunnel's not starting behind Blumensatz's line, if it's starting way up here where the 1 centimeter logo is, then yeah, I mean, this is a tunnel that's going to be out of position. It's going to be a vertical graft. These patients are going to have residual rotational instability and they're going to fail. MRI clearly is a gold standard. We know how good it's used. We know how well it is. And I'm not going to belabor you with this kind of stuff, but an MRI is really paramount. But CT scan is really what I want to talk to you guys about because I use it very routinely in revision ACL reconstructions, particularly for those patients who have had a soft tissue autograft or a soft tissue allograft. For patients that have had BTB or any kind of bony graft procedure, usually you don't worry about tunnel osteolysis or tunnel widening because bone integrates to bone very well, but soft tissue does not really integrate to bone very well. It may heal in the tunnel, but these tend to widen and they tend to cause a problem for us as surgeons. So we always look at tunnel diameter here and tunnel widening, and we look at the widest diameter of the tunnel perpendicular to the long axis of the tunnel. So, let's say we're taking this second picture right here. I'm going to look where the tunnel is widest here, perpendicular to where the tunnel is. And that's going to tell me what my most significant level of widening is going to be. Three-dimensional CT scan is also something that I use very, very routinely in my revision ACL population. It's amazing for telling me where the tunnel is and how big the tunnel is. Sometimes CT scan tells me part of the story, but it doesn't tell me all the story. When I can get some kind of subtraction analysis on a femur, eliminate the medial femoral condyle, look directly at the lateral femoral condyle on FOSS, I can see exactly where that tunnel is going to be. And you can see this is a well-placed ACL graft. It's proximal, it's posterior, the whole thing is behind Blumensatz's line. So, if I can do a CT scan like this, I know for a fact that I can revise this patient in either one stage, or if I need to approach this patient in 2 stages. And obviously the disadvantages of CT scan are radiation, availability, as well as cost. Now, in terms of terminology, we can talk about lots of different things. We can say, is it anterior? Is it posterior? Is it proximal? Is it distal? And if you look on the picture on the right, is it low? Is it high? Is it deep? Is it shallow? All the words are sort of important, but what really matters is it anatomic? Is it anatomic or is it not anatomic? And for me, I want to see that ACL tunnel posterior to Blumensatz's line and proximal, right? So this is a Bernard and Ertel grid, which is a superimposed grid on a lateral view of a femur. And what we really want to do is see that the tunnel is behind Blumensatz's line in this area right here, which is about 25% in the depth and about 35% of the height of this box. All right, so about 25% in, 35% down. If the tunnel's down here, I know it's not good. If the tunnel's down here, then something's clearly wrong. But even if it's like partially off, you know that it's not going to be anatomic. This is just an X-ray view, again, showing where I want to be. And part of it is based on femoral flexion. You really want to parallel Blumensatz's line, and my tunnel wants to be around here. When we talk about the tibial tunnel position, the technique that we most often use is the Stäubli technique, which is the ratio of tunnel depth to tibial depth. So is the tunnel anterior, is the tunnel posterior, or is the tunnel centrally placed? Now, we want our entire tibial tunnel to be posterior to Blumensatz's line. If you extrapolate a line from Blumensatz's line all the way down to the tibia, we want our entire tunnel to be just beyond that. So if a tunnel is a little anterior to that or way posterior, then we know that it's not in the right position. And typically we want the center of our tibial tunnel to be about 45% the distance from the front to the back of the tibia. So this C mark, I really want this about 45% from the front all the way to the back of the tibia. And then when we talk about tunnel widening, why does that even happen? Why does the tunnel widening? And it can happen from multiple different factors. it's usually characterized by osteolysis. Something is going on in that tunnel which is causing bone loss. The etiology is typically multifactorial. It could have to do with the graft that was used, how the tunnel was placed, or certain biological factors, including inflammatory cytokines, whether or not synovial fluid can make its way into that tunnel, because sometimes synovium has all these matrix metalloproteinases in it, which could certainly lead to osteolysis and bone loss. Now, when you have bad tunnels, you get increased strain on the graft. Increased strain on the graft causes graft motion. When the graft moves, we know that the tunnels can widen. And that could be something like a bungee effect, where the graft just wants to go in and out like this, parallel to the orientation of the graft. That leads to tunnel widening, as well as this quote unquote windshield wiper event, where sometimes the tunnel is larger than the graft itself. And this is perpendicular movement of the graft inside the tunnel. That's the windshield wiper effect. And again, that causes increased stress at the tunnel interface with the graft, causes tunnel osteolysis. And then lastly, biological factors, which include graft sterilization, what kind of graft you choose, et cetera, et cetera. Now, when we talk about tunnel widening, there's lots of different ways to classify this, okay? This is a nice view of different kind of morphological tunnels, right? This is a linear tunnel on the left. You know, imagine it just being a straight cylinder. That's linear tunnel, okay? You can have a cavitary lesion where there's really no good way to describe it. It's just a huge amount of bone loss. You can get a quote unquote mushroom type of tunnel widening, where the tunnel widening is more, the more deep you go into the bone. Or you can have like a cone-shaped area of the tunnel. So something like this looks more like a cone, right? It's very wide at the aperture on the tibial surface anteriorly, which is about 17 millimeters. And as you get closer to the aperture inside the joint, you can see that it's actually converging and the tunnel is becoming much more of what it's supposed to be, like a 10 millimeter tunnel. Now, you can certainly use this tunnel, but you'll probably be prone to fail, because if you use such a tunnel that's this wide, you're going to have lots of windshield wiping in this, more graft osteolysis, poor fixation, etc. So this might be one that you would two-stage, fill it up with bone graft, come back once the bone graft is healed, and then do an anatomic ACL reconstruction. Tunnel malpositioning, I talked about before. Again, it causes elevated graft forces, altered knee kinematics, as well as increased impingement of the graft in terms of roof or notch impingement. 3D CT scanning, again, I just wanted to show you a few more pictures. This is on the bottom right, this is a nice 3D CT scan showing an improperly placed femoral tunnel. Now, usually these tunnels are more improperly placed anteriorly, right? So it would be more in this area if you can see my mouse cursor. But sometimes they are a little bit more distally aired. And this one is certainly more distal than more proximal. So this is a nice 3D CT showing that if I put a tunnel right next to this, I might get significant convergence of the tunnels on the femur and have a major problem when I'm trying to fix that ACL graft. Picture on the left is a nice picture of the tibial tunnel aperture in a patient with excellent placement of their tibial tunnel. You can see if you would extrapolate the lateral meniscus, your lateral meniscus would basically come right here. And then this is about halfway at the level of the lateral meniscus. All right, the center of this tunnel is right at the posterior aspect of the meniscus. Technical issues, we know that the #1 reason for ACL failure is tunnel placement. Usually it's more anterior and vertical, and that leads to rotational laxity. This is a nice x-ray right here, which shows that the tibial tunnel is actually very well placed. But when you look at the femoral tunnel, the entire aperture begins anterior to Blumensatz's line. So you know that that's going to be a vertical ACL graft, and that vertical ACL graft is not going to have the same rotational stability as one that would be placed right about here. One of the last things I want to talk about regarding the tunnels is the concept of posterior wall insufficiency and this idea of femoral blowout. Sometimes when we're putting our tunnel in, you can inadvertently drill out the posterior proximal cortex of the femur. And if we do that, then we can't get great fixation. So this is a nice picture here showing posterior wall blowout. You see that the femoral screw, not only is it a smidge anterior, but it's aiming completely posterior. Our screws aren't supposed to aim this way. Okay, our screws are probably supposed to come more along the lines of this when we hyperflex the knee. This is a case of femoral tunnel blowout. You can see some bone graft just kind of hanging out right behind the posterior condyle right there. This is a failed ACL. What I always tell my trainees is that if we have any doubt, we want to stage these procedures. Do them in 2 stages instead of 1. So take out all the hardware, fill it up with bone graft, let the bone heal, then you can come back and basically treat this as if it's a primary ACL reconstruction. Put your tunnels wherever you damn well please, and you won't have to worry about anything. And I always tell them that 2-stage surgery that works is always better than a failed revision ACL reconstruction. And then sometimes we have problems with the hardware. All right, this is a patient that has an Acl Pcl injury after an initial ACL done about 10 years prior. You can see this tibial screw is basically buried halfway up the tibia, and you know that's going to be a problem. I can't just simply drill around this with 2 tunnels, one for the PCL, one for the ACL. Most of the time, this should come out and be 2-staged. This particular type of implant right here is a terrible one because it's very hard to get out with our standard instrumentation. Sometimes you actually have to take a coring reamer, core a huge hole just to get this thing out. And then you're going to be left with a huge bone void. So can you do an ACL revision with a huge bone void? I don't know. Some people say yes, some people say no. This is a great example of a failed ACL posterior lateral corner. I mean, this is one of mine. This is a patient that I did maybe 5-6 years ago. And look at that massive amount of osteolysis in the femoral tunnel. That's a 5mm shaver that's in there. So that 5mm shaver, you could see that I could fit at least another 5 shavers in there. That's about 20-25mm of bone widening. So sometimes it gets very, very difficult to do this. This is a different patient that I had to make the decision whether I wanted to 1-stage or 2-stage. And when I went in there and I saw this video, this is one that's never going to work with a 1-stage because this tunnel is conical. It's about 15-16mm at the aperture of the joint, and you could see that it tapers down proximally and towards the lateral cortex of the femur. So if it was skinny the whole way along, then I think it'd be very easy to do, but you can see that it's about 15-16mm at the aperture. That's going to be very difficult to do a revision in a 1-stage setting. So how do we fill this? There's lots of different ways to fill it. You know, we could take corticocancellous chips and bone dowels or bone putty, something like you see here on the right. We're basically filling a large cavitary lesion with DBM, which is demineralized bone matrix. We could fill large cylindrical tunnels with this kind of prefabricated bone dowels, which are cylindrically fashioned, put it right in over a guide wire, it's press fit into the tunnel. You can even take an osteochondral autograft or allograft device, and you can basically use that to position yourself and then slide in the bone graft through that device. And ultimately what we want to see is we want to see something like this, where you come in 6 months later, you're palpating the joint with a probe, and you can see that that bone is nice and firm. It's integrated very well. We reorient our camera, and that femoral tunnel was completely filled with bone graft, and it was soft when I put it in. And now it's very firm. It's integrated very nicely. We were able to do a revision ACL reconstruction in her without any problems. So those are all some of the issues with the bone, with the tunnels, and with the hardware. And part 2 of this is all the other stuff that we have to think about. And that stuff is on a long, long laundry list. So the first thing that we as surgeons have to think about when we're revising the ACL is, what is the status of the meniscus? Now, not only is that important for pain, swelling, etc., but the meniscus is a very important secondary stabilizer to anterior translation as well as rotational stability. So when you lose your medial meniscus, you've got a significantly increased anterior force on the graft. When you lose your lateral meniscus, that's much more important for rotational stability as well. But when you lose your meniscus, you increase the stress on the ACL graft. This is a great picture of a ramp lesion. I know we talk about them all the time. It's very hard to see on a routine MRI. Some radiologists are much more skilled at seeing these than others, but these are lesions at the posterior aspect of the knee. Generally speaking, where the meniscotibial ligament comes in, or the meniscal capsular ligaments, you can see this meniscocapsular disruption in the back right here. And this is one that's going to place a lot of stress on that ACL graft. So these are lesions that you can't see typically unless you get into a certain position that we call the Gilchrist position. And then you could see it, and then you fix it sort of like you would fix a labrum in the shoulder. And this is the same patient. You can see how nice we can get a repair of, and that will greatly improve the stresses on the ACL graft. Meniscus root injuries are also very, very common in ACL patients, and it's typically the lateral meniscus root that we see. When we usually have a patient with a monster pivot in the office, or when the patient is anesthetized, I usually think to myself, okay, this patient probably has something bad with the lateral meniscus, because it's so important for rotational stability. And a lot of meniscus root injuries are lateral, and they are in context of an ACL disruption. So whenever I see a meniscus root injury, it gets fixed. Unless I damn well can't fix it, I am doing everything in my power to restore that biomechanical function of the root. And then we talk about meniscal deficiency. Okay, and that can be anywhere. It could be in the posterior horn. It could be talking about the body. And we as surgeons don't know how much meniscus loss is too much meniscus loss. We can see meniscus loss on an MRI, but then when we get in there for the scope, if the meniscus is completely void, I know that if I do an ACL revision on that patient, there's a substantially higher chance that that's going to fail again because I've lost that secondary stabilizer. So these are patients that we have to think about meniscus transplants on, and this is a nice picture of a meniscus transplant in a patient that we did in conjunction with a revision ACL reconstruction. And then obviously your posterior lateral corner, your posterior medial corner are very, very important for varus and valgus stability. Increased stress on the graft happens when you have instability of those locations. And then your coronal plane alignment. And typically varus is the bad one. We don't like varus. We don't like valgus very much either, but we really hate varus. When the knee is in varus, it produces a substantially increased force on the ACL. And as you march into more and more varus, those forces on the ACL go up and up and up. So it's not uncommon that we see a patient with substantial varus who has failed multiple ACL surgeries, and these are patients that require an osteotomy. So for me, my indications for coronal plane adjustments would not only include a patient with significant medial compartment osteoarthritis, but also patients with varus without osteoarthritis who have significant instability, because if I don't address that, again, you're doomed to fail. And again, the rationale of the correction is that a knee that falls into varus is going to stretch the ACL out. And we also don't know how much varus needs a correction. So, you can be just medial to the spine through the middle of the compartment or completely outside the compartment, but we have no consensus as surgeons. Obviously, the more varus that you have, the worse it's going to be for the patient, but we don't know where to draw that line in terms of, yeah, this patient needs an osteotomy, or no, this patient doesn't need an osteotomy, but we do have to think about it all the time. This is a 21-year-old soccer player who is status post an ACL reconstruction and a subtotal medial meniscectomy. You can see in the medial compartment of the knee, there's joint space narrowing. There's asymmetric varus alignment of the knee. You can see where the ACL tear was. This knee has significantly more varus than the contralateral knee, and they're developing early degenerative changes. So, for this patient, this is one that's going to do very well with an osteotomy. And sometimes this is what our osteotomy postoperatively will look like, where we take him out of varus, we put him into a little bit of valgus, and here you can see an inset HTO plate with some bone graft material right here to hopefully allow for earlier incorporation and bone filling. Now, the sagittal plane is something that's critically important as well. And essentially, when you increase the tibial slope, you increase the ACL strain. Now, this is a great picture that I always show my residents and my fellows, and this truly can help you understand the concept of tibial slope, right? So if your slope is completely flat, your femur, it can't roll back, right? It's just flat. Your femur's not going to go anywhere. Your ACL, which is this green stuff, is not going to get stretched out. As the slope increases in this second picture, you can see that the femur is now going to roll off the tibia. When the femur rolls posteriorly, that ACL is going to stretch out. It's going to cause increased creep in the graft, increased fatigue, increased stress, and it's ultimately going to fail. And that is why sometimes we do osteotomies in the sagittal plane, a closing wedge anterior tibial osteotomy. And anterior closing wedge osteotomies are a very powerful tool because we can take our slope from about 16 degrees and make it like 3 or 4 degrees. And there's lots of different places that you can do this. You can do it above the tibial tubercle. You can do it through the tibial tubercle, which does require you to elevate that off the tibial tubercle osteotomy, or you can do it below the tubercle. And each one of them has their pros and cons, which I'm not going to get into, but you have to know when and where to do it. And we also need to know that our medial tibial slope is usually more than our lateral tibial slope as well. So, if you see an x-ray and one slope is about 3 or 4 degrees more than the other slope, then again, don't worry, that's probably anatomic. And it can certainly be influenced by the status of our cartilage and the status of our meniscus. For example, if a patient has significant posterior medial meniscus wear, you might get an increased slope because of eccentric chondral wear on the posterior tibia. And then finally, I want to just briefly touch on anterior lateral ligament reconstruction. ALL reconstruction is a procedure which has sort of turned back into the limelight after about 2012 when Claes and Belgium talked about this new ligament that they found. Although we've known about this ligament for many years, it really gave us an increased interest in doing some sort of extra-articular augmentation procedures to replace the lateral capsule when that gets stretched out from an ACL injury. So ALLs, IT band tenodesis, what's really important is to know is that the attachment site is just posterior and proximal to the lateral epicondyle. And also on the tibia, we usually aim for halfway between the fibular head and Gerdy's tubercle, about 1 centimeter distally to the joint line. So you can see a good picture here of an improperly done ALL reconstruction where the tibial tunnel is placed about 4 or 5 centimeters distal to the joint line. Obviously, this is not going to be a biomechanically savvy graft and it's probably going to fail. So you always want to stay anatomic if you can. So now that I talked about a lot of the things that we have to think about with revision ACL reconstruction, I wanted to go over some interesting cases here because this is really where we learn from. This first case is a 25-year-old gentleman who previously had a hamstring autograft ACL in Germany. He was doing well until he had a new skateboarding injury, which was non-contact. Typical presentation, felt a pop, presented with pain and effusion, and he's a high-level recreational soccer player. On the exam, he's got an obvious Lockman, negative varus and valgus. He's got tenderness to his joint line palpation, medial and lateral, and his alignment is pretty much fine. So what you see here is an AP and lateral of the knee, obviously, and here's what I really want to look at. I want to see this lateral, and the tibial tunnel is roughly about 40–45% from the front to the back. So I think the tibial tunnel is in a pretty good position. But when you look at the femur, about part of the aperture is right behind Blumenstadt's line. Part of the aperture is kind of like right in front of Blumenstadt's line. I wonder if this tunnel could have been placed a little bit better, maybe like right around here, proximal and posterior to that. So again, I think about my Bernard and Ertl grid. Where is that tunnel located? Think about the Starbly technique again for the tibial tunnel. And this is really where I think my tunnel is in this particular gentleman. I would have loved to have seen it right here because that's a tunnel that I can just reuse because I know it's going to be anatomic. This is the patient's MRI scan, obviously shows an ACL tear. And this patient had a lateral meniscus root injury, which you can see on this MRI. It just doesn't look right. Something looks a little fishy, a little funky in the back. I couldn't really put my finger on it completely. Excuse me, this is medial rather. The lateral meniscus root, I don't have a great picture of it here. So medial meniscus tear, lateral meniscus root, I know on this patient is out because I operated on him. We did get alignment films on this patient, but this patient had symmetric mild varus of both knees. It just goes just medial to the tibial spine here. So I didn't think that we needed to address this with an osteotomy. Here's a CT scan showing that the tibial tunnel might be just a smidgen posterior. I would like it to be a hair more anterior than this, but I've certainly seen worse than that. And here's his 3D CT reconstructions, showing again that the tunnel is not properly placed. I would love it to be right in this area here. Tibial tunnel looks like it's in a pretty good location. Arthroscopic correlation, these are the prior ACL graft fibers, which look terrible. They're completely stretched and stripped. Wall is completely void of any kind of insertion right here. He does have a lateral meniscus root avulsion. Hard to see, but my probe is right underneath the lateral meniscus root here, and you can see that it's clearly detached off the tibia. So I put 2 stitches in there, drilled a separate independent tunnel into the lateral meniscus root attachment site, fixed that, did his ACL revision reconstruction. I was actually able to get a nice new tunnel right here, nice and proximal and posterior, right behind Blumenstadt's line, fixed him with a BTB autograft revision. This patient ultimately did well. This is a view of his lateral compartment after the root tear. You see the meniscus is coming in and the root's going to be dunked in the back right there. This is the second case. This is a 32-year-old gentleman with a failed ACL with a BTB allograft done 5 years prior. He's an active soccer player, plays 3 nights a week, but can no longer play, secondary to pain and recurrent instability. He had retore his ACL about a year prior. Here's his x-rays of his knee. Can't really see the tunnels too well here because it was done with BTB allograft. I think there's been a fair amount of bony integration, and there's no hardware in there. So whoever was the prior surgeon used some sort of radiolucent screw, whether it be plastic or biocomposite. You can see a little bit of joint space narrowing on this AP film. But if this is his tunnel where I think it is, I think it's in a pretty darn good location. It's kind of right where I wanted it to be. And here's the tibial tunnel. Again, if that's where it truly is, then again, it's a well-placed tunnel. Here's his MRI. We've got coronal T2 weighted images or fat SAT or whatever you guys want to call it. My wife yells at me all the time for getting this wrong, but I do that without apology. Complete ACL tear. And then you look at the medial compartment, a little bit of cartilage loss, and he's relatively devoid of meniscus, right? He's certainly meniscus deficient on that side. And you know that the meniscus is a secondary stabilizer of the ACL and the knee, that this patient with an ACL done alone is probably going to have a higher chance of failure. We did get alignment films on him as well. This is the bad knee right here. Interesting that this patient actually had more varus on his good knee than he had on his bad knee. So in this context, again, this probably wasn't enough for me to consider an HTO, especially because this patient was meniscus deficient. So this is a patient that we ultimately did an ACL revision reconstruction with a medial meniscus transplant. And here's a nice 3D reconstruction showing his graft is exactly where I wanted it. So here's an arthroscopic correlation. Excuse me for 1 second. Arthroscopic correlation. Medial compartment completely devoid of meniscus. He does have a small cartilage injury right here on his medial femoral condyle. We drilled a new femoral tunnel for him since the other one had completely incorporated in. Pie crusted the MCL with a spinal needle to get better access to the medial compartment. We drill our medial meniscus root, pass our meniscus graft, stitch it up, do our ACL, and here you can see a medial meniscus transplant on the right with a new ACL on the left. And that patient ultimately did very well. This is the last case I wanted to show. Another interesting case is a 24-year-old female soccer player who failed 3 ACL reconstructions and subsequently was sent to me for care. Her first one was a BTB autograft, which failed, and the second and third were BTB allografts. She had another pivoting injury while playing soccer, presented to me with a 2B Lockman examination, and very, very mild posterior lateral rotational instability. Didn't have any varus or valgus instability, no tenderness to palpation. It was purely an instability type picture. If I show you, there's the ACL tear. And if I show you sagittal alignment pictures, what I really want to point home here is that her tibial slope measured about 16 degrees, which is about 8 degrees more than the normal slope should be. So I measured about 74 degrees from this line straight up the tibial shaft, down the slope, 74 degrees or 16 degrees if you subtract it from 90. So obviously that slope is very high. These are well-placed tunnels. The reason that this female failed is because there was unrecognized tibial slope problems. Her femur kept wanting to roll down this tibial slope right here, so it stressed out the graft like crazy. If you look at her alignment film, she's in a touch of valgus, not tremendous, just a touch of valgus, just lateral to that tibial spine. Again, not enough to make me think about an offloading osteotomy here, but just enough to pique my interest. And then you can get a CT scan just showing the differences between the medial and lateral slopes. Here, the medial slope looked like it was 77, lateral slope looked like it was 75. It's tough to do with a CT scan because obviously you don't have a line going straight down the tibial shaft, but just to get a general gestalt, I think it's kind of helpful. This is her intra-articular examination, which showed a small meniscus tear longitudinal in the back that we fixed with 2 stitches. You have a ACL that's completely dysfunctional, completely stretched out. Part of the fibers were intact, but you see how stretched this graft is from here to here. It's clearly not working. So this is a patient that we did a slope reducing osteotomy on. You go in from the front, you drill some K-wires to basically plan out your osteotomy. You're going to remove this triangle of bone right here in an attempt to close down this slope. So once we do our osteotomy, we fix it with 3 staples. You can see that we used a BTB allograft here. Here's an interference screw in the tibia, interference screw in the femur, and you can get a good closing wedge osteotomy and do the ACL at the same time. This patient is 6 months post-op, has done remarkably well after this kind of procedure. And that's our ACL graft at the end. And you can see just what we corrected her to. We took her from about 76 to about 84. So if you think about the slope, that's gone from 16 degrees to about 6 degrees. So I'm very happy with this reconstruction. I'm very happy with this correction, and this patient has actually done very nicely. So with that, I'd like to stop. That's been a very thorough talk, I guess, on ACL revisions and things that I look for as a clinician, trying to get some radiographic correlation in there with you guys and give you a sense of the things that I look for as a surgeon when it comes to ACL revision reconstruction. So thank you to all. And at this point, I'd like to open it up for any questions.
Yeah, thank you so much, Michael. That was fantastic. I can start with a question that I had. So you mentioned that ACL grafts can fail structurally by tearing, but also functionally by basically not doing its job. So I think we're okay with, towards MRI diagnosis of graft failure and rupture. What is your recommendation or experience in diagnosing these basically grafts that lack capacity but are continuous on MRI?
So it's a really good question, and it's very hard to tell a patient, hey, your graft is intact, but you need to be revised. We do come across it. Typically, those patients will complain of persistent functional instability. They feel that their knee will buckle, give out on them. You get an MRI, and there's an intact graft. Although the graft may be intact, their Lachman may be positive. They may still have an endpoint, but you might get more translation than the contralateral side. They will often have a positive pivot glide or pivot shift in the office as well to show that rotational laxity that you might get. And the other thing you can do is take out what's called a KT arthrometer. So you can actually show a patient just how loose it is by slapping a KT arthrometer on their knee and measuring the amount of anterior tibial translation on an examination. So despite the radiographic diagnosis of intact graft, functionally that graft is probably stretched out because of a multitude of variables, whether it be improper tunnel placement, meniscal deficiency, ligamentous laxity in varus valgus plane, coronal sagittal malalignment, sort of like that last girl had, where her ACL was still a little bit structurally intact, but it was loosey-goosey. So that's the things that I look for. I mean, radiographically, it's very hard for you to make that diagnosis and say, yeah, this is functionally unstable.
Yeah, that would have been my follow-up question, whether, there are signs or even, if there would be an expectation for the radiologist to, at least, when we go into the area of making suggestions, which means I think, but I can see it directly, then we're getting in deeper water.
Yeah, well, then you can also, as a radiologist, you could also look for persistent anterior tibial translation in the context of a structurally intact graft. You could look at meniscus deficiency, especially posterior medial meniscus deficiency. And sometimes people get this little cupola, which we call, which is isolated cartilage wear on the posterior aspect of the medial tibial plateau. And that shows me that, okay, there's too much stress on the back of the plateau. Why would that happen? That would happen because of recurrent anterior tibial translation. So that's one thing you could look for. And the other thing you could look for is bone contusions, right? I mean, if people have pivoting bone contusions in the context of an intact graft, then the graft probably is not doing its job.
Yeah, those are great tips.
I have a question.
Excellent. Yes, go ahead.
I've had some interest in the past in fixation failure, not because of improper tunnel placement, but fixation devices. And I wonder if you find failure more often with different types of fixation, whether it's interference screw or cross pin or metallic or bioabsorbable.
So short answer to the question, I guess, is no at this point. Cross pin fixation, we do know had a very high failure rate. That's why we stopped using them. I never used cross pins in practice because they were out of style well before I even started practice. When I was a resident, a few people were still using them, but when we realized that they weren't doing a good job, then we bailed on that. Interference fixation, whether it be biocomposite, PEEK, metal, really no difference borne out in the literature. I mean, some of my partners use biocomposite or PEEK. I'm a metal guy because I like to know where the screw is if I have to revise it. I don't want to have to search for it. There's lots of different reasons to choose one versus the other. We don't have enough data yet on this sort of all-inside graft failure. So we're doing a lot of ACLs now where we're suspending it off the tibia, suspending it off the femur, just with a button on the tibia, a button on the femur. And we've got good data at like 5 years. Some of those patients actually do pretty well, especially if it's an autograft. There's not as much tunnel widening as there would be with an allograft. But I think the current methods of fixation that we have are very good. I'm happy with them. It's very, very rare to see an early failure from a fixation device issue at this point.
Okay, one other question. I know that my biggest nightmare is when somebody re-injures themselves kind of in the short post-operative time frame when we're still looking at, you know, immature grafts, right? And I know that those are the kinds of cases that my colleagues and I always consult each other on because we don't know what to do with it. I mean, from a clinical perspective, is there a time period that you would wait after a re-injury to re-image?
No, I mean, if I suspected they retore, I would just get an MRI right away. I'd probably cry for about an hour, then send them for an MRI, then cry again for the next hour. But, you know, it's not going to heal. If it tears again, it's done. You know, it's got to be revised. Thankfully, most of our patients are compliant and don't have early failures. But in the rare case that we have one, yeah, I mean, we revise it when the patient is ready.
And do you have a standard complete pre-revision imaging algorithm that you follow, or is it the same in everyone?
Pretty much same in everyone. MRI, any patient that's done with a soft tissue graft gets a 3D CT recon to evaluate for tunnel widening and tunnel placement. For bony grafts, the bone's going to be incorporated, so I really don't care so much about osteolysis. Every patient gets standing alignment films, coronal and sagittal. Every patient gets 4 view radiographs, including a PA flexion to determine if there's any kind of medial joint space narrowing with a little bit of flexion, which might, again, lead me towards the path of meniscal deficiency or subtle varus. So for a revision, they all get the same thing, unless it's a BTB. Then they just don't get the CT scan.
Very good. Thank you.
Okay. Just checking if there's any questions in the chat.
Yeah, no chat questions.
No chat question. I have one more question for you. So regarding the tibial slope, Michael, so you showed some pretty sophisticated measurements with probably a software, but do you think you can measure that accurately on MRI, given that you usually don't have enough, you know, not that much tibia, and I would think you need a longitudinal access through the tibia to really measure it, but other than suggesting it, can you measure it on MRI?
You can try. It's not that accurate, and it has a pretty crummy inter and intra-observer reliability. There's been like 1 or 2 studies that have looked at comparing, and I think the one that still is listed as the best is a full-length tibial X-ray, believe it or not.
Okay, yeah.
So the MRI is nice, Jan, because you can see meniscal deficiency and cartilage loss, right? So you know, you can measure slope based on the bone, or you could take the cartilage and the meniscus into account as well. So I guess an MRI might give you more of a flat slope, I guess, because you have to think about the cartilage and the meniscus being involved, but a CT or an X-ray might show you a little bit more slope. But the bony morphology is more important.
Right. So bottom line, you can suggest it on MRI, but probably best to not provide quantitative or numerical measurements.
It's hard to do.
Yeah. Okay.
do.
Okay, great.
If you can come up with a way to do it well, then you might get rich. So we'll see.
Yeah, it's my daily search. Okay, all right. Any other questions from the audience or Hillary?
No, I'm out of questions. Why don't you call it? Wrap it up. Yeah.
Okay, excellent. All right. So thank you very much, Michael. This was fantastic. And these arthroscopy videos are very impressive. And I think that's what we all visualize when we look at the MRIs, or at least try to. So thank you very much for giving this great lecture.
Happy to help. Have a good day, everybody.
Thank you, Mike.
Bye-bye.
Bye-bye.